Thank you, Alan. I appreciate that. What he means is I'm old. That's what he means. You had Johnny Depp up here lecturing before. Now you get Mel Brooks. That's the difference, you see. You know, when Alan gave me these topics, the titles that they made up these titles, but he told me what to talk about in terms of topics, and I realize now that Ben got all the less controversial things, and I got all the politically sensitive things. And so before this is over, I expect that there's going to be somebody who hates me on every single topic because I'll have struck a nerve in some way, shape, or form, especially when I talk about healthcare. So we're going to talk about treating MS, and Ben already set the stage for that very nicely. There is a storm that we talk about going on in your central nervous system, in your brain, and in your spinal cord that we want to calm down in some way, shape, or form. So I'm going to introduce a term that the Minnesotans in the audience, these two people at least I know of, know this term, right? You've heard the term, garage logic. It's a term that I started using because I stole it from a radio personality named Joe Souchere, who's still a radio personality in the Twin Cities and was a sports writer and then a feature article writer and still is doing that in the Twin Cities. And the term I really like, and I started using it many, many years ago when I used to talk about topics that didn't make sense to me, and yet people were accepting them. There were so many things in multiple sclerosis that if you used a little common sense, you would not get yourself involved with. But people, for whatever reason or other, seem to lack common sense about things. And common sense sometimes is best done when you're sitting in the garage, not with the car on, with the car off, and you're relaxing and you're not impeded by all the stimuli that are around, and you're away from the hustle and bustle. So we have had a lot of things in MS that did not make sense, but for whatever reason, they were very, very popular for about 6, 7 years, and then they die out. Bee stings, for example, were very, very popular for a period of time. Who in the world would think that stinging yourself with 25 bees would cure MS? But lots of people did. And I can tell you point blank that when I used to lecture about how that didn't make sense, people got angry, very, very angry with me. How many people now get bee stings on a regular basis? No, hardly any. There's still a few, but hardly anybody. Cobra venom, pregnant cow's milk, goat serum. I was sitting at a big event across from a celebrity. I'm not going to mention names, but he was taking goat serum when I had first met him, probably about 10 years ago. And he didn't remember meeting me, of course. And he's no longer doing the goat serum. I mean, but he was so sure that that was the cure of his multiple sclerosis. Removing your mercury amalgams. Chronic cerebrospinal fluid, venous insufficiency. Operating on veins. To cure multiple sclerosis? Come on now. It makes no sense whatsoever. And yet I was in the Denver airport with Joyce Nelson, who was the CEO of the National MS Society several years ago. She's now passed the torch to the next person. And she came up to me, knows me well, I was on her board. She came up to me and said, "This is so exciting. We're going to be doing $2 million worth of research on CCSVI." And I said, "That's a pile of crap." And her face went blank. And then she remembers to remind me of that every time I see her after that, because it was a pile of crap. And we spent lots and lots of money on that, and it made no common sense whatsoever. Hyperbaric oxygen, various diets that people have been on, and on and on and on. So a lot of the things that I'm going to try to emphasize in the next 3 talks that I give are common sense things that we should take a step back and understand from not just a neurologic perspective, but from a common sense perspective as well. Understanding that tracking the storm, this is high in multiple sclerosis. It starts with the selection of your DMT. And now I'm very curious, how many of you who have multiple sclerosis are on a disease-modifying treatment? Let's do this the other way around. How many of you who have multiple sclerosis are not on a disease-modifying treatment? Okay, very few. And you know, Ben and I talked about this earlier. There are a lot of neurologists who feel quite appropriately from the literature that if you have a more progressive form of the disease, you are wasting your money and time on being on the drug. Ben and I don't agree with that necessarily. And when I'm speaking for the pharmaceutical companies, which I do a fair amount because that's my retirement job is to lecture, I can't talk about that because it's off-label and inappropriate. But I'm not speaking for them here. So I can give you my personal feelings that if your disease is getting worse, we should be doing something about it. If it's not getting worse, that's one thing. One of the things that I've learned over the years, and we heard a question about menopause, and I didn't want to chime into the thing, but when people get into their 60s with MS, typically the disease slows down. I used to say that it burns out of sorts. Typically it slows down. Now, that's not true of everybody, that's for sure. I've diagnosed people in their 70s, but it's true of a fair number of people, and that's true of all autoimmune diseases. It's not just multiple sclerosis. They all tend to slow down. The immune system tends to poop out when people get into their 60s. So it's not unusual for people with a more progressive form of MS to level off and not get worse. And I've seen people look the same, come in with a walker 30 years later, they're walking with a walker. Are they walking the same? No, they're 30 years older. And I can tell you that there's not much difference between being 40 and 50. There's not much difference between being 50 and 60. I can tell you there's a difference between being 60 and 70, and I'm beginning to feel the big difference between 70 and 80. And so you know, things that has nothing to do with multiple sclerosis, that has to do with garage logic of getting older, things don't. So if your disease is getting worse, we would like to do something about it one way or another. This, as been alluded to, the studies, they're not so great. But in every one of these studies on progressive MS, there were a cadre of patients, as he said, who seemed to do better on the drug. If we could tell who those were up front, that would be fine. But we can't necessarily. And so there is a certain amount of trial and error. So how do you select a DMT? What tools do we use to track this? So this is choosing the proper treatment. How do we choose the right? We want the right disease-modifying treatment for the right person at the right time. In spite of what any pharmaceutical company may tell you, there's no one drug that's right for everyone. We want to choose the right drug for the right person at the right time. No two people with MS are alike. And so it's hard to find one size that fits all for everybody. We don't know the exact mechanism of action of each DMT. They're not known, but we know that there's a variety of actions across the almost dozen DMTs that we have available to us to choose from. Now I want to talk about something that we learned before there were DMTs. Ben, have you been practiced? Did you practice before there were DMTs? Barely. So you can see the age. I did half of my practice before there were any disease-modifying treatments. We learned a lot about multiple sclerosis before there were drugs. And you know what? Most people have forgotten that. Most people have forgotten what we learned. What we learned before that we had drugs is that with no drugs at all, 1/3 of the people who got multiple sclerosis ended up in a nursing home. 1/3 of the people who got multiple sclerosis ended up with disability, but in the community. But 1/3 of people who had multiple sclerosis did well with their disease. We forget about that third. And in fact, some people get so academic about it, they want to believe it didn't occur. So the Mayo Clinic many years ago did a study. They looked at everybody in Olmsted County, and they found 35–40% of the people in the county in Rochester, Minnesota, around Rochester, Minnesota, had had multiple sclerosis for 25–30 years and were doing well. That was more than what we expected, more than actually we expected. And when the person presented this data at the meeting, his name was John Noseworthy. John Noseworthy is still around. John Noseworthy is now the CEO of the whole Mayo Clinic. He runs the whole show. But when he presented this data as a neuroimmunologist, he didn't believe it. But there they were, the data. And you know what the first question from the audience of neurologists was? Did you do cognitive testing on all those people? Because they're all probably brain dead, but they walk and talk. Yeah, that was kind of a dumb thing to do, because if you met these people, and I did in my practice all the time, they were very normal people. And you wouldn't go testing everybody who was normal just to see if they had a little blip here or there. They were very normal. 1/3 did well. The trouble is we don't know who that is at the front end. We don't know. We can't tell you who that is at the front end. Numerous studies have shown us that 20% of the total will do very well, and we developed a term that we called benign multiple sclerosis. Now, I don't know about Ben, but I don't like that term. I don't like it. It's an oxymoron. So let's call it mild multiple sclerosis. 20% are going to do well. Autopsy studies in the past, which we don't do anymore, but we used to do autopsies on everybody virtually who died of no matter what, but it's too expensive, so we don't do it anymore. But they showed us that there were another 8 to 10% of people who had multiple sclerosis who had died of other things and didn't even know they had it. Didn't know they had it. So there are lots of people who have multiple sclerosis who may never come to the diagnosis. But how do we know who they are and how do we separate them out? So our adage for most neurologists is we want to treat 100% of the people up front, but we know only 80% really need to be treated. But it's easier to treat early than to treat late. It's hard to close the barn door after the cows are out. So we're in the era of shared decision making. Do I like that? Not particularly. It was a lot easier for me when I just made the decision. You know, I was trained by the father of American neurology. His name was A.B. Baker. Dr. Baker founded the American Academy of Neurology. And Dr. Baker used to go to people and say, listen, sweetheart, you have, I can do that, it's my wife. You have demyelinating disease. Yeah. There was no internet. Nobody could figure out what that was. He said, but don't worry about it. I'll take care of you. Yeah. And you know what they did? They said, yes, Dr. Baker. And they walked out happy. So if I did that today, listen, sweetheart, I'd get kicked out of the door immediately without even saying anything, let alone. So we're in an era of shared decision making. We're all involved in the decision, but who should be making this selection of what medicine? These are complicated neuroimmunological drugs that have lots of issues, and we're going to talk about risk and benefit over and over and over again, the risk versus benefit ratio on these drugs. And unless you're trained into this, you don't have the capacity to separate the wheat from the chaff. Garage logic tells you that you're paying that doctor for advice. Listen to that advice. But on the other hand, you have to take the medicine. And if you don't buy into it and understand it, you're not going to take it because they're not simple medicines. They're not just, even the pills are not simple medicines. It's not a matter, just take this pill and there's no issues. We heard about CD4 cells today. I mean, how many of you would ever thought that you'd have to deal with that? With a pill? And yet we have to deal with things. They're not simple. So my job, Ben's job, all of our healthcare providers' job, the nurses' jobs, are to educate our patients so that we get on the same page so we understand what the risks, benefit, and make the appropriate decision. So we talk about all the time about relapsing multiple sclerosis and secondary progressive multiple sclerosis and primary progressive multiple sclerosis and progressive relapsing multiple sclerosis. I hate those terms. And I was involved in making them. You know, but there was a reason for it, and the reason was research. Way back in the 80s, we were failing in research. And why were we failing? One of the thoughts was because we were studying multiple sclerosis, this pot. And we studied things, did studies, decent studies. But in the pot were bedridden people next to ambulatory people. Same drugs, same medicine, same outcomes. And nothing worked. Surprise, surprise. So we said, maybe this disease, multiple sclerosis, we need to separate out a bit more. And we came up with these terms. We had other terms before, but we came up with these terms to be universally accepted for research. They weren't meant for anything else. And so the first study was done with beta-seron, and that study was done in a randomized, double-blind fashion with 2 doses of beta-seron, and it worked. And the FDA said this drug is approved for, and we all expected them to say, multiple sclerosis. But they didn't. They said, this drug is approved for relapsing, remitting multiple sclerosis. And it was like the birth of a new disease. And you know what? It did not matter. We didn't care. We had a drug. And then came Avonex, and then came Rebif and Copaxone, and we didn't care that they were all approved for relapsing multiple sclerosis. And now, as we heard this morning, we have all of these drugs, all approved for relapsing multiple sclerosis. And you know what? We didn't care until the insurance companies started asking us, well, this person looks like they have progressive multiple sclerosis. You wrote that down. Now, doctor, this actually happened to me 3 days ago in Tampa at a meeting with managed care. Managed care doctor said, you know, we're not going to tell you how to prescribe. You're the doctor. You know what to do. We're no experts on this. You're the doctor, but we're going to control costs, so we're not going to pay for it. Well, if they're not going to pay for it, it puts a little bit of a limit on how we do things to some degrees. And so those patterns of disease, they're out the window now. We've decided that they don't make a lot of sense in today's modern world. So we can't get rid of these terms entirely because they're so ingrained in us. But now we talk about relapsing forms of multiple sclerosis that are fluctuating, that are active or not active. So that benign multiple sclerosis isn't having attacks. What do you call that person? Well, we're going to call them relapsing multiple sclerosis, but not active. They may have disability. You may be walking around with a cane, having had a number of attacks, and then suddenly it's stable. What do we call it? Active or not active, relapsing multiple sclerosis. Then some people get progressive, but they stop progressing. So if you have somebody who's progressive and they've stopped progressing, what do we call them in the past? Progressive. But they weren't progressing. So now we've got some common sense, some garage logic in this. And so we talk about secondary progressive that's active. And it is with or without progression. And then primary progressive, worse from the get-go. Some of those stabilize and they're not progressing, and some of them are active. And we got rid of the progressive relapsing form of the disease. But active may be your MRI is active. It may not be that your disease is showing progressive disability. We may see new lesions on the MRI. That's a sign of activity because we have tools now. And we look at those tools. We look at the diseases. We look at the individual. We look at their disease course. We look at their MRI. And then we make a decision. Do we need to treat or not? And I can tell you that when I practiced, and I retired now, but when I practiced and I probably took care of, when I was doing this, more MS patients than any single person in the world, by a single person as opposed to a clinic. But when I retired, I had people come in before I retired every day and ask me, how am I going to do? How am I going to be in the future? And I would look at them and I'd tell them, I'll tell you how you're going to be in the future. If you'll tell me how I'm going to be in the future, I can't. I don't have a crystal ball. I can't foretell what's going to happen to people. I don't know who's going to do good, but I can tell you this, and I know Ben knows this, we know who's going to do bad, who's going to do badly. We can tell who's going to do badly because they have bad prognostic indicators. That person with the sensory ataxia that he described has got issues. We've got to worry about that person. Clumsiness, klutziness, spasticity. And I don't mean the spasms that were treated with quinine. I mean spasticity, which is velocity dependent. The faster you move the extremity, the stiffer it gets. If you have that early, that's not a good sign. Cognitive issues. A bad-looking initial MRI scan. Later on, it doesn't correlate very well, but initially it correlates with a bad prognosis. Poor recovery between attacks. More spinal cord problems. If you're male, if you're African American, if you had late onset MS, if your disease is progressing, these are bad prognostic indicators. And when we see them, flags go up and we say to ourselves, we need to treat this person more aggressively. So the person who comes in with 24 contrast-enhancing lesions on their MRI and looks klutzy and cognitive problem, but there's a first attack, we're going to look at differently than the person who comes in with a little numbness and tingling and some blurred vision and has 1 or 2 lesions and may not even make the criteria to make the diagnosis. We look at the individual, and then we have to look in deciding which drugs to use. At their psychological work issues, what are their personalities like? Because we have to sell this drug that we have determined is the best drug for them to them so that they will take it. We have to look at their personality. We have to look at where they're a depressed type. If they have severe depression, we don't want to use an interferon because that may make it worse. And so we have to look at the individual, their work-related problems. I had people who were flight attendants for Northwest Airlines. Unfortunately, Northwest Airlines doesn't exist anymore. It's not part of Delta. But they didn't want to take medicines on their flights, their flight attendants. So we looked at medicines that were easier to take because of that. Stresses and fears. We looked at practical issues. We heard about insurance issues, and they're getting to be more and more, as we'll talk about when I give that talk, more and more difficult to deal with every day. We have to look at hand coordination. Can they do the things that need to be done? And their support system. And then we look at to decide treatment. We recognize that all of these treatments will work for somebody. That's why they're approved by the FDA. They didn't get approved because they were done. They got approved because they worked. But they didn't work for everybody. And so we know that they're different. The pharmacology, how they work is different. Even within the classes of interferons, it's different. Dose-dependent differences. Even with strength, the differing effects on the immune system with the monoclonal antibodies hitting different parts of the immune system, different side effects, different routes of administration, and different risk versus benefit ratios. Very different risk versus benefit ratios. We're going to come back to that over again. So then we choose a DMT. So how do we do it? Well, we look at what kind of MS do they have? How aggressive is it? That's the phenotype. How does it look? We look at that. And then we look at the individuality of the person who has MS. What's going to fit into their lifestyle so that they will take this medicine? And then we look at the variabilities of the DMTs and we make a choice. We make a choice. And we sell that choice with shared decision-making going back and forth so that we're all on the same page. We make the choice and then we give it time. We give it time and then we see, does it work? Does it work? That's not very complicated, but for some reason it's become very political in the neurological field, and there's lots of lack of garage logic in dealing with this. So the choice may fail at times. Sometimes the choice fails, and we recognize that. It may be because it simply doesn't work. We put it in that person, it worked in the studies, didn't work in that individual person, don't know exactly why, but it's not working. And maybe because they're not taking it appropriately. You know, it's a twice-a-day oral medicine, it's not working. Maybe it's because you're only taking it once a day, and it only works if you take it twice a day. There's lots of reasons. That may be because of side effects or toxicity. It may be because the person's just not feeling like they want it to work, and they see everything negative about it. We have to understand that when we determine success, there is no cure. No cure out there. So how do we determine success? Well, we look at, and Ben mentioned this, and I'm going to mention it, you'll hear it over and over again. We look at relapses. Relapses. I'm going to define that again and again, but he did an excellent job at defining. It's a new neurologic symptom, or a worsening of an old one, but preferably a new neurologic symptom lasting 24 hours or longer. And I like it to actually be accompanied by a finding, something I can see, not just a little numbness that's here and there, because everybody gets that, and they're new here or there. So we look at relapses. It's a little nebulous, but it's not that nebulous. We look at the disease progression, the neurologic examination, walking, talking. Cognition is part of that. Vision is part of it. We look at the neurologic examination and score that so we have numbers to understand. And then we look at the MRI. We look at those three things, major things, to determine whether the disease-modifying treatment is working. And then we ask, what do you think? And people have a feeling about how it's working. We have this new term that you've probably not heard about. It's called NEDA. NEDA. It has some pros and cons associated with it as far as I'm concerned. But NEDA means no evidence of disease activity. If we had no evidence of disease activity, I would call that a cure. But we don't have that, but we strive for that. We strive for that. So how much disease activity can we accept? And that's variable from individual to individual. But we'd like to get to NEDA if we can. We measure it against this hypothetical idea of no no evidence of disease activity. We're going to say, you're a little bit over that or a little bit under that. But really, we have to measure it against your past history of disease. This came up in this managed care thing that I was at in Tampa, where the question is, if you get an MRI, what do you do with it? And if you have 24 contrast-enhancing lesions, you start a disease-modifying treatment, and you have 3 6 months later. Is that success? Or are you not there yet? And it depends, I guess, on how the person looks. But you're measuring it against the past history of how they're doing. If they go from 3 relapses every 6 months to 1 relapse every year, are we going to be satisfied with that? It certainly sounds successful, but it'll depend on what that relapse is to some degree. And then we have to measure, look at the drug in terms of toxicity. So we talked about relapses, but I want to talk about what an MRI relapse is, because we do MRIs periodically. When I was a bit younger, I used to poo-poo that to some degree, but MRIs have gotten better, and maybe we've gotten better at how we interpret them. So how often should you have an MRI so that we can tell whether that disease-modifying treatment is working? And there's no set answer. But at this managed care thing, where we had an internist and 2 pharmacists as the managed care experts, and they said, well, do you need 1 in 6 months? And the comment was made, well, if we're changing drugs, we sure should have 1 in 6 months to see. They were surprised. There's no common sense to their thinking. Of course we're going to look at that and see whether it's working or not. But, you know, you do 1 every year or 2 if things are stable for a while, and then you may stretch them out. But we don't have X-ray eyes, or magnetic eyes, if you will, to see inside. So we want to know what's actually happening so we can make appropriate choices before problems occur clinically rather than after. So sometimes we see enhancing lesions and tell us that the MRI is having a relapse, if you will. This is an example of a physical relapse with the sagging of the face here. Here's an MRI relapse with a bunch of contrast-enhancing lesions. Doesn't take a rocket scientist to tell that this person's going to be in trouble if we don't do something different with them. So we look at disease progression. We look at the examination by doing a neurologic examination. We score it, and we look at function. How is the person doing? And we remember that if they're not successful, if we're failing, we switch drugs. Simple as that. And I tell my patients, these are not sports teams. You know, I'm a Minnesota Viking. It's really hard to be a Minnesota Viking. But no matter what, I'm a Minnesota Viking. I lived in in Colorado, and I was a Minnesota Viking. I live in Arizona, and I'm a Minnesota Viking. These are not sports teams. You may be on Avonex. You're not an Avonex person. It's not, I'm an Avonex person. I'm a Rebiff person. You're not. They're drugs. And if it's not working, you switch drugs. It's as simple as that. Don't get emotionally involved with this. This is a necessity to switch drugs. But then you weigh the risk versus benefits of the switch, because switches are not all wonderful. There are hazards to switching drugs. Hazards. Remember the reason you're taking the drug in the first place. And remember how it stabilized you or didn't stabilize you. You've got to think about that, not just forget that as if it was nothing. You're taking it from the point of view of you're trying to stop disease progression, prevent new symptoms, and improve the quality of life. That's why you're taking it. So switching should be for a good reason. It should be because the relapses or disease progression are still going on, that this is not good enough for us, and so we're looking to switch the drug. That the disease has progressed by your neurologic examination, or your MRI is getting worse, and your quality of life is no good. Those are good reasons to switch. The switch may not work, though. So it's not so casual as, oh, I'm going to switch and everything's going to be wonderful. You've got to consider maybe that switch will be not so good. Maybe you'll end up worse. Stable disease may actually worsen. So if you're stable, you come in and say, you know, I'm stable on this injectable, and now there's this new oral, I want to take the oral. You're taking a big chance, not a little chance, because it may not work. What's going to be next?
Love you.
The drugs in the studies may work well, but the outcomes over the long haul may not be the same. So the switch may not work. It may be when you switch that it takes the drug a while to build up in your system before it works, so you're vulnerable for that period of time. It may be that the side effects of the switch may be worse than the side effects that you started out with. So people say, well, I don't like that injectable, and then they get diarrhea or nausea on the switch, and they, oh, give me back that injectable. It wasn't so bad after all. So you have to look at the short term and the long term. What appears easier may not be better. It may be harder to stay on a drug that you switch to, even though it sounds good. And I'm a big believer in it shouldn't be about the mode of delivery. IM, sub-Q, PO. It should be, what is that you're putting in the body? What is that? Pills can be very toxic and shots can be very benign. B12 shots, very benign, but they're shots. Some of those cancer pills can kill in an instant. And so it's not about what way you're taking it. It shouldn't be. It's about what is it that you're putting into the body. And different formulations may have different effects on different people. So there may be costs in monitoring when you make the switch. And there are safety concerns. And the switch strategies haven't been tested over long periods of time. You may switch from natalizumab to something else because of a PML scare, and you get a rebound that makes your MS worse, and you wish you hadn't switched because of that. So you've got to weigh risks versus benefits. There's lots of things, even within a single class of drugs. So if the disease is progressing on the current treatment, by all means, switch. But if the disease is stable, making a switch will not result in improvement. And it gives you a significant risk because what we're trying to do is maintain stability. So what about relapses? So we talked about the physical relapses, we talked about the MRI, and now for a moment we're going to come back to what Ben was saying. I'll give you a little bit older perspective on this. Does it need treatment? And I concur with what he said entirely. You know, if we had the patience to just let these relapses run the course, potentially they would all probably end up the same whether we treated them or not. But it's a matter of function. It's a matter of function. And if we decide it needs to be treated because a person's function isn't working, what do we treat it with? And because of a lack of common sense, neurologists have taken something that made no sense in a study looking at optic nerve disease, and they came to the conclusion that treating with oral steroids may actually worsen MS. So there is a cadre of neurologists out there who for some reason have some conclusion that's based on nothing factual that doesn't want to use oral steroids, especially lower dose oral steroids. And I can tell you after doing this for 40 years that that conclusion is ridiculous, but they will insist on that. So you can use a lower dose of steroids for a milder attack, and often that will do the trick, oral steroids. But steroids are very much the same as the disease-modifying treatment. Dose matters, and so if things aren't working well, we tend to up the dose. The route of administration makes no difference whatsoever. Taking oral steroids, taking shots, IVs, I can tell you it makes no difference whatsoever in the effect of the steroid because it's well absorbed. But it may have a difference in side effects. There may be different side effects if you're taking large doses of oral medicines versus a shot of the medicine. ACTH I cut my teeth on. We gave it IV in the hospital, 10 days, and that's what we did. Dirt cheap, had nothing else. Then came the era of high-dose steroids, which I ushered in, actually, that era of high-dose steroids, and we cut our use of ACTH down. Adrenocorticotrophic hormone stimulates the body to make steroids. And then that was brought back, and the company bought it and brought it back. It's an effective drug. And after an initial pricing that was rational, they decided to price it differently. They had lots of political reasons for doing so, but they priced it kind of out of the market. It's an effective drug, but cost, problem. We have to be concerned about that. And when you have a relapse, should we change the DMT immediately? It's a judgmental thing. I can tell you that if I saw a person who was doing pretty well and all of a sudden had a relapse in which they couldn't walk or talk, and that's happened, I'd change the DMT after the steroids. I wouldn't feel comfortable with that, leaving that alone. On the other hand, if it's a relapse in which they had a little bit of clumsiness, a little bit of spasticity, you gave them some steroids, things stabilized, we would watch and see how they went. For a little bit, at least have some patience. So in summary, reviewing, is your DMT working? Look at relapse, looking at disease progression, look at MRI, look at how you feel, look in terms of this hypothetical, no evidence of disease activity. We're going to measure against that, and then we're going to look at how is it really working in comparison with you. We'll look at toxicity. We want to look at the psychological issues and the practical issues, and then make a decision. And with that, I'm going to be gone until next time. Thank you.